Again, this ground round is going to be recorded and it's going to be in our YouTube channel. Ruth already mentioned about the two educational opportunities that are coming, and Ruth is going to present the speaker for today's ground round that is a member of our Children's Hospital and Norton Healthcare. Ruth?
Sure. Thank you, Dr. Ramirez. I am so delighted to have the chance to introduce Dr. Aaron Calhoun. I actually met Dr. Calhoun on accident. It was one of these great accidents that happen, and I have come to learn and appreciate not only his knowledge as a clinician and an educator, but also his interest in simulation. And I think his service as part of the National Association that is helping helping us explore and implement new ways of teaching and learning, and the importance of that visual component and the real life experiential side. So Dr. Calhoun has agreed to talk with us today about the art and science of conducting healthcare simulation, and I am so appreciative of your time. Dr. Calhoun, let me turn it over to you.
Great, thank you so much, Ruth, and thank you, Julio. I really appreciate the chance to be here and to speak to you all. My name is Aaron Calhoun. Again, I'm professor of pediatrics and critical care, but the focus today is going to be on what is healthcare simulation, really to try to give an introduction to what it can accomplish, to how it works, and really to focus more on the doing of it. What does a session look like? What is the evidence behind it? And at the end of my talk, I would like to move towards some ways that this might apply to the work of this group in terms of infection prevention, more as a suggestion than anything else, and hopefully we can begin to discuss there. I'll just ask too, feel free to throw comments in the chat if you would like. If not, we can discuss afterwards. I may ask Ruth if you can monitor the chat, and if something comes up that you think would be worthy of interrupting and answering in the middle, just please stop me, and we'll kind of do that as we go through. Just to quickly discuss disclosures, I have received recent grants from Sanofi Pasteur and Robert Wood Johnson Foundation, and I also receive honoraria for my work with the Society for Simulation Healthcare, where I both serve as a member of the board of directors and also as the associate editor-in-chief for the journal Simulation in Healthcare. So a quick outline of what we're going to talk about. We're going to talk briefly about simulation as a field. There have been multiple textbooks written on sim, so this will just be dipping our toes into the water. But to understand the value of simulation, we have to talk about adult education theory, just briefly. And then we're going to go through 4 different models of how one does healthcare simulation that vary from perhaps one of the older, more venerable models, simulation with reflective debriefing, to some newer versions of it, and focus on the difference they can make clinically in terms of provider behaviors and outcomes. Finally, we'll talk about simulation infection prevention. I have some thoughts in terms of how just-in-time training and what you'll hear about later is called rapid cycle deliberate practice could be incorporated into infection prevention work in a way that could hopefully really make a difference in how people utilize the equipment they have when infectious disease like COVID or on the horizon monkeypox arrive. So first, let's talk a bit about educational approaches. And to really understand this, it's important to understand the concept of adult education theory. Those of you that do work in pediatrics will perhaps understand have heard the dictum before that children are not small adults. And it turns out in terms of teaching, adults are not large children. And so while there are many theories and frameworks out there, the cold cycle is a particularly well entrenched one in the world of simulation. And so just to go over this will hopefully give a feel for why simulation can be important. So this theory of how adults learn starts with the idea that adults don't just sort of learn things in a vacuum or learn things randomly. We learn things based on problems we see or issues we encounter in the real world. We see a problem, we want to solve that problem to make our lives and the lives around us better, and that leads us through a cycle. And so first we have an experience. This can be really anything. Perhaps a patient in the floor or who gets a hospital-acquired infection for potentially preventable reasons. This leads us then to reflective observation, where we consider what happened, we think of what went well, what could have gone differently, and we consider methods perhaps by which we could have intervened on this, reflecting on the experience. That leads to an abstract conceptualization where we formulate an idea. We come up with a plan. We come up with some new model or framework in our head that says, you know what, next time this happens, I'm going to do this and here's why. And that leads to active experimentation. We actually try it. We actually go out there and do what we thought we would do. And of course, that causes us to have an experience, and the cycle begins again. So where does simulation fit into this? Because the example I used was primarily a clinical example. Well, if you think about how simulation is used in other industries, simulation is often, think of it in the airline industry to make sure that pilots have adequate experience and reflection, conceptualization to handle events in the sky should they occur, engine failures, things of that nature, or even perhaps in space travel with all the simulations that NASA astronauts undergo in order to be able to fly. The same thing is really true in healthcare. Rather than have these experiences on actual patients, simulation gives us the capacity to have these experiences in an artificial environment where nobody, and in the case of infection prevention, that both includes the patients and it includes the physicians or nurses or other clinicians, can be injured more or less. Then in a controlled debriefing process, people are guided through reflection and conceptualization that gives them something new they can do in the future. And then of course, that can even be tried out in simulation so another experience is had. And so this cycle can be enacted multiple times in a non-clinical setting that replicates the clinical setting so that individuals can have an opportunity to practice and gain the expertise they need. So the first time they see a patient in a given situation, they can have a much higher chance of doing it properly, of not transmitting that infection, of placing that line right, of doing the procedure right, of doing the resuscitation right, avoiding patient harm, and again, in cases that involve transmissible diseases, perhaps potentially avoiding getting infected themselves. So we're going to talk a bit now about a typical simulation with reflective debriefing as the field was kind of founded on. This is the first model that we used. And so we're going to have a lot of these diagrams. I'd like to show you the structure of some of these sessions and go into some of what goes into making a simulation work. And then we'll talk about some variants that can sort of up the productivity of these. But a typical simulation, I have this one mapped out as about an hour, begins with something called a pre-briefing. It goes into the session proper, where the actual simulation is conducted, and then it goes into a debriefing afterwards. Now, what'll probably become pretty apparent from this diagram is that the majority of time is spent in the debriefing. And in fact, the simulation itself really isn't where the learning occurs. This is something that I think people that are just coming into this field really have to kind of focus on getting their heads wrapped around. Learning doesn't happen because of what you do. It happens because of your ability to reflect on what you did and create new schema or mental models in your head. And so in fact, a good debriefing usually lasts longer than the actual simulation itself. Flipping to the beginning, the pre-briefing up front is really meant to set the stage and make sure that the environment and the rules of the game, the layouts, the rules of engagement are known for people entering the sim. So let's go through these different components step by step and talk a bit about what goes into them. And then we're going to talk about, again, how to rearrange these as needed to fit different circumstances. So key things in the pre-briefing, number one is introduction of the technology. Now, there is, I think, potentially a myth that arises thinking that all simulations require high-end technology, whether virtual reality, whether a $60,000 high-fidelity mannequin. But in reality, some of the most effective simulations I know are conducted in sub-Saharan Africa using a program called Helping Babies Breathe that uses a $4 plastic mannequin of an infant that you fill with hot water so it feels real, and has a simple compression device you can use to simulate an umbilical pulse. And it's used to train basically rural African midwives in how to safely deliver basic neonatal issues that can occur in that setting. Very low tech, very low cost, uses all these principles. So technology, it's the prop. It's whatever you use to conduct simulations. I've conducted simulations like this where the only technology was Zoom, and I was talking people through a story, much like my son does when he has his Dungeons and Dragons weekend. You're telling a story, you're engaging people, you're getting them involved in a shared world, and you're helping them think through a situation. So there's many ways this can be done. Next, discuss scenario fidelity and what's known as the fiction contract. This is a bit of a sim jargon, but it's an important one to understand. It's kind of hard to ask for hands online, so I'm not going to, but my sense is that most people these days enjoy going to the movies or engaging in some kind of electronic entertainment of some sort. So whichever one you prefer, the fiction contract is basically what happens when you say, I'll pick one I like, go to a new Marvel movie. And you walk in there and you know full well that Dr. Strange is not real. You know full well that the characters are imaginary and that what you're watching on the screen is not actually happening. But for that hour, you've paid good money. And so you are going to engage in what's known as a fiction contract. You're going to say to the makers of the movie, I'm going to suspend my disbelief in what's happening and accept what you're giving me as reality. And what you're going to give me in turn is entertainment. You're making a contract with the author of the fiction. Simulation is another way of using fiction. It's another way of telling stories. And so it's important to really explicitly engage with people and say, listen, this is not a real baby. This is not a real patient. I know that. This environment is as close to reality as I can get in the ways that we need it to be. It's not perfect. I know that. I need you to buy in. I need you to come into this with the attitude that I'm going to behave and think as I would in real life. I'm going to work on this. I'm going to deliberately make that choice. What I'm going to give you in turn is an experience that we can use to make your clinical care better. And so the more explicit you make that up front, the better. No simulation is 100% realistic. And so having this fiction contract is vital. You can also discuss general strategies for navigating the situation. What are the ground rules? What's the boundary between real and not real? This is a particularly important one for learner comfort. What counts as part of the sim? If somebody walks into a room and says, excuse me, we have an emergency down the hall, is that part of the sim? Is that part of reality? Are they really pulling you out? It's important for people to know where reality ends and where simulation begins. If people know what the boundaries are, they're far more comfortable engaging in the fiction contract. You also do know some likely issues that will be encountered. Prime people for success, although you don't want to give them all the right answers up front. Give them a sense of what might be happening in the room. And then finally, give some goals and objectives for the scenario itself. Simulation proper, this is actually an image of a sim that was conducted in New York, but it shows the degree of equipment and realism that can happen if you need to go in that direction. Create a realistic clinical environment, provide, if possible, a realistic clinical team. This is actually more important, because a lot of simulation, especially these, the longer sims with reflective debriefing, really are focused on teamwork and team interaction. And so you have to have a team that feels like the team that would be entering that clinical event. Continue during the session to encourage suspension of disbelief. And the goal here with this type of simulation is to remain immersion, minimizing educator presence. When I'm doing these, I never give hints. If somebody's looking at me for a hint, I just shake my head. They shouldn't be looking to us to give them prompts. They shouldn't be looking for us to teach. They are there to interact and have an experience. The teaching will happen later. There are a couple different ways in this sort of standard practice to do the debriefing. I showed you the traditional up front, which we'll go into a bit in a second. But there's also a model called micro-debriefing I want to mention too. And this can be really useful for less experienced groups. But if in the first structure of it, you do a pre-brief and you do a session, and then you leave the room and go to a debriefing session, micro-debriefing is what happens when you kind of chunk up the debriefing and you insert it at key elements. So they go through the scenario a bit, and then they hit a key decision point. And you wait and you see what happens. And then you say, I'm going to hit a pause. Let's debrief what happened in this 5-minute piece. And then you talk about it, and you say, great. And then you move on to the next piece. And so this can be helpful when you have teams, especially of student learners, that might easily get lost in a more complex case, when you still want to give them that experience of going through a complex case, but you want to make sure that they have adequate information at different time intervals to successfully move on so that you can kind of phase through it. The reflective approach with the longer debriefing, again, this is meant to occur after the sim. And the choice really depends on which you use and the situational educational goals and the learner group. So reflective is typically best whenever you have more experienced learner groups, when they have some degree of knowledge of the subject matter, when they focus on higher level interventions like teamwork, communication, especially things that are going to be interpersonal. It allows for a more immersive experience, but it can actually give you higher learner stress levels since they don't get a break. They just go through the sim as if it was real life. Reflective micro-debriefing can be best in novice groups when they have lack of knowledge of the subject matter, and so you're going to have to give them little injections of knowledge throughout the simulation. When you focus more on granular skills, when you're looking at, okay, how do they do the bag mask ventilation? Let's pick an ICU scenario, that's my home base, and let's talk about that. And it can also allow for mid-course corrections during the case. They could be moving in the wrong direction, but after the debriefing, they might make some decisions that change the directions they take it. This can give novice learners a greater chance of being able to succeed in the environment, and this can lead to lower stress levels. The right choice really depends on the team. Going to some debriefing suggestions. If you've ever been in a sim debriefing, you might see some of these. These are some key ways of asking questions that can really facilitate the process. The first is one called plus delta. We don't tend to talk in debriefing about positives and negatives, because the goal of a debriefing is not simply to deconstruct the experience they had, it's to make positive changes in behavior for the future. It doesn't matter what happens in simulation. What happens is what matters the time they see this in reality. And so he talks about strengths, responses they had that they would repeat. And then we talk about things they would change, hence the delta, things that they would alter for future times that they encounter either this in simulated or real life. So we mentioned that instead of weaknesses. What went well? What would you do differently next time? It keeps people thinking in that future mode. Another key tactic is something called Advocacy-Inqui, and honestly, there are entire courses on this. But just to briefly introduce you to this concept, this is a way of getting at the frame of reference of learners. And this is pretty critical for what we do. So consider this. Consider a learner who asks for the administration of an inappropriate drug during a simulation. And that causes a negative result to come. So one mistake that people do is they reflect on the action and say, you know what? I noted that you gave this drug. And they'll say something to the effect of, maybe you shouldn't do that next time. Here's why this is a bad idea. Feedback is given. That decision is short-circuited in the future. However, we don't know why they gave the bad drug. It could have been a lack of knowledge. It could have been a lack of communication skills. It could be that somebody else, that they knew that the drug was wrong, but somebody had asked them to do it. And they didn't know how to challenge the medical hierarchy. And so these frames is short for frames of reference. And this refers to all the potential things inside somebody's mind that may have led to that decision. And so what we talk about in debriefing is acknowledge the action. You gave X drug. This led to this outcome. Let's talk about it. Question the frame. I'm curious as to why that decision was made. Can you share what was happening in your mind, what your thought process was that led to that decision, so that all of us can benefit from the experience we had? And so using this kind of a process allows you to potentially not only solve that action, but diffuse a number of actions that may have come from an inappropriate frame of reference. So that's, in a nutshell, how we used to conduct simulations at the very beginning, at the outset of the field. There have been a number of different evolutions in how we do this that can focus perhaps our efforts better on specific areas or problems. And it's these that I think might be the most useful to this group. I want to focus on three. One is rapid cycle deliberate practice. The next is mastery learning. And the third is just-in-time training. And this picture comes from one of my son's board games called Evolution. It's a fun game if you ever want to play it. So what is rapid cycle deliberate practice? So this basically is giving do-overs. You have your pre-briefing, you have the session proper, you make sure to limit the session so you have enough time for this, you debrief, and then after the debrief, you run the session again. Same session, same content, and you give people the opportunity to solidify the lessons learned during the debriefing, and then debrief it again to solidify that also. So really, it gives you a way of practicing again and again, doing it in a very deliberate fashion. That's where the title comes from. It's defined as a learner-centered instructional design strategy that identifies performance gaps and targets feedback to improve deficiencies. And so really, it's because of the reflective approach. It doesn't give you the chance to cement new behaviors. And so these cycles then give you an opportunity, especially when this is focused on particular skills. This is great when it's like you're focusing on the first 5 minutes of a code, say, and you want to know how to give good bag mask ventilation or good CPR, or maybe your process for donning effective PPE when going into the room of an Ebola patient. That can be easily done in 5 to 10 minutes, and then you can give reflective debriefing and reflective practice on that. I'd like to get into some evidence now to show that this is useful. And so here's several studies that look at rapid cycle deliberate practice. Betsy Hunt did RCDP training for resuscitation, and they were able to achieve a 40% reduction in no flow time during CPR, which is huge, and an almost 2 times higher chance of defibrillating within AHA recommended guidelines. Corey did the same for sepsis management and was able to have some significant improvements in sepsis management checklist scores. And then McGee looked at this in neonatology and was able to also show some improvement in resuscitation checklist scores, as well as likelihood of administering timely positive pressure ventilation, 100% versus 71%, and epinephrine. So there's some really good evidence forming out there in the simulation literature that if you're trying to modify specific skills that are sort of high impact, RCDP, rapid cycle deliberate practice, is really the way to go. Now, mastery learning. If The rapid cycle is sort of a do-over. Mastery learning is sort of give me another 20. So this takes that concept to the next extreme and says, you know what, why give them 2 sessions? What if they do poorly after the second session? Why not give them as many sessions as they need to get the level of mastery that is required for this to be adequately done? And so this seeks to step outside the whole idea of time-based instructions. We typically think, well, I have an hour for a lecture, I have an hour for a sim, I've got to do everything inside there. And mastery learning says, hold on a second, those are constraints that are artificially placed. Now, there might be good reason for them, given the conflicts people face in other areas of their lives. But in terms of the education itself, why not step beyond the idea that we need a certain amount of hours of instruction and go to everybody needs however much instruction they need to get it right. So it can be time consuming, but it's effective. And the positive of this, of course, is that while somebody might need 2 hours to get the skill down, somebody might only need the first sim and they're done in 20 minutes. And so the goal here is that you set a clear mastery standard. This is the minimum amount of performance that we need to achieve as mastery. This is not just sort of a passing, like below this you fail. This is, we're going to get everybody to an A- at least. What is the A- cutoff for this skill? It's most effective for, again, really mission critical skills. You set that standard ahead of time, and everybody keeps engaging in the cycle repeatedly until everybody meets the standard. So everybody comes out with an A, but it takes some people longer than others. The evidence for this is pretty strong. It's great for procedural training. Barsak et al. Looked at mastery learning to improve thoracocentesis outcomes and had a significantly fewer clinically meaningful pneumothoraces. I should add that this is in the real world, not just in simulation. That's where her study was. And then Cook et al. Did a 2013 meta-analysis of simulation-based mastery learning and found that compared to no education and compared to traditional simulation, there were significant benefits in skills and in actual patient outcomes and in skills also compared to other means of sim. So this approach really does seem to have a significant impact on how people behave in the real world when they interact with real patients, and it's an impact for the better. And so it's a process that if you have time to do it, and there's a certain core set of really focused skills that you can clearly define a level of mastery that you need to be able to practice that skill safely, this can be an effective means of achieving that. Next is just in time. And this, in a sense, is much simpler than what's gone on before, but this is more or less last minute training. The key to this is not the structure. You typically do a quick pre-briefing, quick simulation, and a quick feedback session that might not be as elaborate. But the whole goal here is to do it at the bedside. So a great example of this would be, let's say a simulation where I'm in the ICU and I'm there in the morning and I recognize that I have several patients that are at high risk of cardiac arrest and potentially requiring CPR or maybe ECMO. We've done this in our ICU with ECMO, with congenital heart patients that are unstable and might need ECMO. And so we do, at the beginning of the shift, we get the people that are going to be involved in their care. We do a 15-minute, ideally no more than, session where they quickly go through a simulation that practices the skills they need to successfully navigate that issue. And then we set them loose to practice and to do the care in that environment. And the goal, of course, is to give a brief injection of knowledge and skill that occurs within 12 hours of potentially having to use it so that you don't have any knowledge decay and that you've been refreshed. The goal here, again, is to choose a patient who's at high risk of needing a specific procedure or experiencing some outcomes, and then giving all this at the bedside. And the data is actually pretty compelling. One of the first studies is by Dana Niles at CHOP. And she looked at doing just-in-time CPR training in the PICU setting. They brought a cart to the bedside of patients likely to have a cardiac arrest, and they practiced until they were able to successfully perform CPR, defined by AHA guidelines. And they were able to achieve successful CPR on the patients 46 seconds sooner. Branzetti also did the same in a cardiology context. It's a little bit, maybe a little bit more subspecialty specific, but looked at transvenous pacer placements, and they were able to show they almost have the time of double their improvement in the clinical skills checklist and significantly reduced their critical emissions, all at a significant p-value. And so, you know, these suggest that the idea of just-in-time training can be a way to directly impact imminent clinical care, imminent clinical behaviors using a simulation-based method that is not as time-consuming. So for the last 5 minutes, of my talk, I'd like to talk a bit about simulation infection prevention and suggest some strategies, and then hopefully open it up to questions and discussion. So many of the examples I give, I've kind of drawn from my personal experience in critical care, but how can this be used for your field, the field of infection prevention? How can this be generalized and disseminated? Well, a couple ideas. One would be the use of just-in-time training. This is actually a perfect use of this means of approaching simulation. So take, for example, a hospital ward preparing for one or more highly infectious patients, let's just say Ebola. And the problem is, how are you going to be sure that the clinicians on that ward can appropriately don PPE? Well, this is, again, somewhat staff intensive. But if you have people that are on site, you can do on-site point-of-care simulations in, say, an empty room on donning and doffing PPE equipment. This would be very low tech. You don't need a mannequin. You don't need a patient in the room. All you need is the room itself and the right equipment and the right environment to conduct this in. And again, the right people to observe the process so that you can be assured that they've done enough times to really have it down. I think this could very positively impact people's ability to don and doff PPE in difficult, potentially highly infectious situations. So how could you perhaps amplify this? Well, if you incorporated RCDP and mastery learning, as I mentioned, that can even strengthen it. Rather than just doing it once, you would do it multiple times until a certain threshold of mastery that's been defined is reached. This also adds additional possibilities and additional things that could help out, because if you do this enough times in different areas of the hospital that are encountering this, you might begin to notice different patterns. Now, simulation is often conceived of as an educational modality, and that's where it started. But the reality is that if you do any simulation in situ, so on the ward, in the clinical environment, using on-staff people, which you would need to do for just-in-time training, it's likely that you're going to notice things like maybe they're out of gowns, or maybe there's a supply issue where there is inadequate types of gloves, say, in the hospital that day. Perhaps one of the negative flow rooms isn't working appropriately when you go in the room to check it out as part of your process. And so these are latent safety threats, and they can be diagnosed and detected in a simulated capacity before you actually stick an infectious patient in there and infect the rest of the ward. And so the use of simulation to explore latent safety threats in actual clinical environments is rapidly growing, is in fact I'd say one of the more rapidly expanding areas in the field. And so doing simulations like this not only improve the care the team gives, but can actually potentially prevent errors that are beyond the team's control in the moment. Again, this need not involve high fidelity mannequins or significant expense. This is the Helping Babies Breathe mannequin I mentioned, along with the instruction sheets. It is literally a balloon that you fill with hot water, and it has one tube that goes to that squeezer, so you can give a pulse at the umbilicus. So simulation is not necessarily tech dependent, although technology does exist to make things more realistic. So I really meant this as a really brief kind of high pressure overview of some of the things that can be accomplished, of the literature that we have, and some of the theory behind sim. I hope this has been useful as a real brief intro to this. There's a wide array of goals and approaches to simulation, and really the best approach at the end of the day depends on your learning objectives, your learner group, and the available time you have. There is substantial evidence out there to support the use of this technique as we seek to educate our learners. And there's some low-cost methods that really exist that we could use to meaningfully apply this to infection prevention. I would also say, too, that the global simulation community is in the process of conducting a very large-scale review of the literature from the last 20, 30 years on simulation, and is hopefully going to come out with global guidelines for practice by next time this year, that could hopefully inform further actions. So with that, I'm going to conclude, open up for questions, turn it back over to Ruth, and see what questions or thoughts you might have.
Thanks very much. This was an excellent overview. And I think, one of the challenges that we have in infection prevention and control are doing a lot of those at the bedside engagements with patients where we don't see the negative impact of what we do. So it's not like that if I make a mistake, I immediately see development of infection. So we have to very much be looking at all of the steps, the procedural steps in tasks.
Yes.
So knowing kind of that, and so the ability to really incorporate a lot of high fidelity simulation then is perhaps of less benefit than doing something as you described with that rapid cycle or in situ type of training. Can you give some insight? If we have particular situations, so wanting to demonstrate for like environmental services, cleaning and disinfection appropriately, or accessing a line, an intravascular device appropriately, or something really complicated like cleaning a piece of reusable medical equipment like a scope. With those situations, can you just offer some ideas for how perhaps to approach the use of simulation?
Yeah, you asked some really good questions, and I'd like to take 1 second to kind of address the idea of fidelity, and then go into the specifics because I have some specific thoughts on that. But one thing I would say too is that when you're looking at simulation fidelity, this just gets at the cost of the equipment. It isn't just about fancy equipment. There are different aspects of fidelity. There's cognitive fidelity. Are people having to think in the room the way they would think in real life? There's emotional and social fidelity. Do people feel in the situation the way they would in real life, or do they interact with their peers in the situation the way they would in real life? There's environmental fidelity. Is the room realistic? Are we doing this in a sim center? Are we doing this in the hospital? Are we doing it in some, they have sim trucks now that have paintings on the walls that look like ORs. Are we doing it there? What's the fidelity there? And then there's, of course, the mannequin fidelity and the patient fidelity too. So I would say you got to think about the fidelity you need for each. So the situation you described, I want to focus on the ESD staff aspect of it. I would say that to do that sim, the first thing you would need to do before ever launching that would be to sit down with a number of experts, both from an infection prevention standpoint and from an ESD standpoint, some of their leadership, and say, what are the core steps? What are observable key things that if people do this, we can say they are able to do this accurately and successfully. And then you'd have to come up with some kind of way of just analyzing, checklisting, measuring that in the environment. And you would want a lot of environmental fidelity for the sim. So you would not necessarily need, in fact, if the patient's already gone, you're cleaning the room, you don't need a mannequin at all. What you need is just some basic props to put on the room to make the room look lived in. And then what you would do is you would have 1 or 2 observers in the room. You would instruct the ESD people to go in to clean that room. You would go through the checklist. You would give them feedback, and then you would, if the adequate amount of mastery had not occurred, you would do it again, and you would just cycle through it a few times until the ESD folks felt comfortable with the decontamination procedure and that all the steps that your team had deemed mission critical had been hit. And to do this just in time, this would be like a way to do this just in time. Maybe it would be hard when a patient's coming. But let's say a patient's transferring from, I'm just going to pick a state, Texas, with Ebola. Just thinking of where we had our one case back in 2014, and they're going to be coming here. So they're coming the next day. You would try to get a hold of the ESD people that would be on that day. And you would say, let's just spend a half an hour together going over decontamination procedures. And rather than talking or lecturing, you would have them demonstrate what they know. And then you would give feedback and have them cycle through a few times. And so that's kind of how you would need to do that. The key is establishing the mission critical nature of the procedures. And really only sort of evaluating based on things that are like, yes, if they don't do this, the next patient to get in this room will probably get Ebola. Or if they don't do this, they will get Ebola. Again, I'm picking on Ebola a lot, but something like that.
Monkeypox.
Or monkeypox, yeah. And so that's kind of how you have to think through that. And so you have to have a sense up front of what you're observing for and have that established already. Does that make sense?
Yeah, absolutely. Absolutely. Those are great points. Great points. I like especially the discussion about what is fidelity, because I've thought only about fidelity being in terms of like use of a mannequin or not. But I think that your comments about making it realistic and in all areas can get people to be really embedded in the situation, so yes, that they're really it's becoming a very real environment and thinking about then what is happening and the impact of what they're doing. So it's excellent.
Yeah, there's a lot I've been thinking about and trying to do when I talk to people lately to sort of disconnect to some extent the idea that simulation is entirely tech dependent. It's as tech dependent as you need it to be for the thing you're trying to solve. But a simple tabletop simulation of a mass casualty drill is probably more effective for, say, a potential bus crash than having like 40 mannequins in the ED. You don't necessarily need that. What you need is to simulate the thought process. So you need high cognitive fidelity. You don't necessarily need mannequin fidelity. You're not applying the care. You're just trying to figure out where to put the patients. That's something you do over the phone. So have people do this over the phone, monitor the phone line. Think about the realism that's needed to solve a problem that is being solved.
Aaron, you clearly mentioned then that in all this process, the critical aspect is debriefing.
Yes.
And I know that, I mean, there's a lot of science and literature on debriefing, and the problem is that then let's assume that in our group, we are going to do some simulation, and we're going to have 4 or 5 people that are going to be doing debriefing in different areas. But really, we don't have the time to take a course on debriefing. Then could you emphasize what are the critical points of debriefing, and also you can, at your time, give us some reference. What would be the article that we need to read to get the basic for debriefing?
Absolutely. And that's debriefing, first of all, is one of the toughest things to do in SIM, as I think you all recognize. I'm going to go over just quickly my approach to sort of a longer 20-minute debriefing session, since those are the most intense. And then I'm going to post in the chat link a free tool, a cognitive aid that is useful for those getting into debriefing. I'll also offer too, if any of you would like to do a session on debriefing at any point during this, because you're actually doing this, I'd be happy to do that and go into it in more depth. But in the way I typically approach debriefing is, first of all, I try to do it outside of the clinical environment, because you want people to be a bit at ease. This is especially if they've had like a longer experience, or maybe something bad happened. You can perfectly well debrief in the room, but I try to get them somewhere else where they can kind of sit down and think. And then I start with what's known as a reactions phase. How did the event feel to you? And that gets at fidelity. Did you think the thoughts you would have thought if this was a real event? Did this feel as stressful as a real event would have felt? Did it seem real to you? Just to get people talking, just to kind of open things up. And then in the debriefings that I do, I tend to have a very defined pattern to go through it. I'll ask about teamwork and interpersonal stuff. I'll ask about procedures, and then I'll ask about sort of the medical aspects of it. And you'd have to reorganize those based on the thing you're debriefing and the content of your SIM. And then finally, at the end, we kind of summarize take-home messages. I think the key with debriefing, though, is not so much that general flow, but it's how you ask the questions. And this is the part that people have the most difficulty with. So let's take an example of a simulation that I actually conducted, where I may have set this up so that an individual would give an inadvertent dose of potassium chloride, so that I could have a discussion about some of these issues in the simulation to the mannequin, and a negative outcome happened. So the first mistake people have is they go in and they'll say something to the effect of, so what happened during the sim? It's very vague, it's very open-ended. There's some value to open-ended, but if the room says it all went fine, there's clearly a problem there. You're stuck, you can't really share much. The reality is you observe something. You observe that a medication was given, and you observed a negative outcome. So the second mistake is the exact opposite, which is going into the simulated environment, or going into the debriefing and saying, all right, I noticed that you all gave a dose of calcium chloride here, and that caused the patient a negative outcome. Don't do that again. So you're giving the feedback. It may be a bit confrontational. There's ways of saying that are not confrontational too, and so get the point across, but you're not engaging the learner. You're just simply lecturing. You're providing information. That's a bit better than the previous one, because at least maybe they'll remember that. The third way is a way that asks the learner and the team to think. And that's what I was getting at with that advocacy inquiry. So the way I would ask that question is I would say, I would use the language of observation, that the patient had a dysrhythmia. And before that dysrhythmia, I saw that you gave a dose of potassium chloride. Now, at this point, you can actually give your judgment gently, respectfully, but you can give your judgment. I'm just going to tell you, as the facilitator, that's what led to the dysrhythmia. However, I'm more curious as to the thought process behind the choice of that drug. Can you share with me what was going on in the room, what was going on in your mind, what was going on with the team? Then you just step back and let people talk, and the stuff you find out will be really interesting, and that opens up further questions. The best way to debrief is to learn how to ask questions that get people to look at their own frames of reference and thought process and open themselves up for change. I'm gonna share again real quick a website that I just pulled up. Let's see. Where is it? There we go. So this is the Debrief to Learn website. I put the link in the chat for all of you want to look at it. This is a free tool that you can use. It's an approach to debriefing. It was published in 2015 in Simulation Healthcare, which is the journal that I work for. There are so many papers on debriefing that to give you a sample even would be huge, but this is a great place to start. And this has actually a downloadable pocket card you can bring that gives you prompts and hints as to questions you can ask. So setting the scene, reactions, description, analysis, how do you frame questions? Here's some sample phrases, what aspects were managed well and why. We actually have this as a reference card on all of our simulation equipment, so people that are less experienced with debriefing go through. So if you're interested in debriefing, I would urge you to download this. It's a great entry-level tool for the field.
Excellent.
Do we have any other comments or questions?
Nothing else that I'm seeing in the chat. I know we had a couple of people mention that they're working on the development of some simulation approaches. And I think this was particularly of interest and important. As I mentioned, we'll be combining this at our boot camp with taking some of the content that the CDC has developed as part of Project First Line. That's the basic infection prevention and control information. And they've developed a lot of education, a lot of here's what you need to do. And then we intend to take it one step further to say, all right, let's take this information that you have provided and let's put it into action. So coming up with direct examples of how to apply this to enable not only individuals at the bedside, but also those that are still in training to figure out how do I use this and develop, my approach, the, I guess, art part of healthcare based upon the science, and then how we can bring that so the information is just more than education. It actually results in, in changing outcomes and reaching that desired level of practice, which is so important because in infection, we don't see the direct impact of the decisions we've made. That infection develops days, weeks, sometimes months later. So we have trouble with establishing those relationships. So I think you've given us some great tools that we can use and begin to see how we can overcome that.
Thank gap. You. If I could add one piece of sort of things we've learned in other domains of simulation that might help in that endeavor, it would be try as hard as you can to develop an approach that, number one, focuses on training the trainer. So what a center really needs to maintain good infection control using SIM is not, us sending a team to the center and doing like a whole day and then never going back for a year. We know that doesn't work. The literature on that being ineffective is pretty clear. Unless they're going to get the case the next day, the skill decay is pretty rapid. It's gone by like 4 or 5 months. It would be better to have small focused interventions that happen every few months at each place. And it would even be best if the major intervention that your team did was perhaps to find local champions, give them the skills and the ability and maybe the low cost, low fidelity equipment, if it's something that a grant could give or something, to continually do updates at their site and then empower that site to be a sort of a self-sustaining educational center that can do just in time or can do at the very least like, a 2 to 3 month rolling refresher for everybody who's involved in that unit. Time limited, but frequent. Short time limited bursts of simulation are far more effective than long one-day courses that don't get repeated for like a year or 2 or 3.
Absolutely. Great. This is excellent. Very good. Thank you so much. I don't see any additional questions in the chat, but I know all of us are thinking about how we're going to use this, how we're going to apply the information, and how we're going to take this next step. So I hope that you'll be open to returning for not only another session, but also of hearing what we're doing and providing some feedback.
Oh, absolutely. I think the work that this group is doing with infection prevention is exactly what simulation should be engaged in. And so if I can be of any assistance or I can do anything to help further the strong work that your group is putting together, just let me know. Happy to come back whenever you need me.
Thanks very much. So, Dr. Ramirez, you want to close us out?
Yes, as always. I mean, we are. I hope that everybody enjoyed these grand rounds as Ruth and I enjoyed. This is. I mean, Aaron started saying how adults learn. And I have to tell you that I mean, we are learning every day. So interesting to figure out how is that we are learning. And Aaron has been excellent clues. And as we always discuss, this is supposed to be one of our most important hobbies. When people say, "What is your hobby?" Just learning. And this is what we're doing here in these ground rounds. Then we'll see you in the next round. Aaron, thank you very much for this excellent presentation. And next Wednesday is going to be another one of our own. Ruth, you can tell us the topic.
Yes, Matthew Song, one of our ID clinical pharmacists, will be talking about the risks of antimicrobial use.
Thank you very much.